Hello, everyone. My name is Dr. Aidan Sharkey. I'm an attending anesthesiologist at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And today I'm going to be talking about lung and gastric ultrasound. We're going to be discussing why, when, and how. I have no conflicts or disclosures to discuss. The outline of my talk today is to first give a brief introduction and background to the concept of gastric and lung ultrasound. And then I'll get into the meat of the presentation, which is to talk about lung and gastric ultrasound. And my plan here is to do this in a case-based discussion where I will present cases based on lung and gastric ultrasound and show how we utilized lung and gastric ultrasound to direct therapy in patients. So before we talk about lung and gastric ultrasound, let us take a step back and define what exactly is point-of-care ultrasound. Well, this refers to the use of portable ultrasonography at the patient's bedside for diagnostic, monitoring, or therapeutic purposes. Lung and gastric ultrasound, which we will be discussing today, are under the umbrella of point-of-care ultrasound, which also includes abdominal, cardiac, airway, regional, and vascular access, to name a few. The use and incorporation of point-of-care ultrasound into clinical care has exploded in recent years, and this is primarily due to technological advances in ultrasound equipment. The evolution of ultrasound systems from large cart-based systems to more portable laptop-based systems to handheld pocket probes that we currently utilize has allowed the rapid expansion of focus. What was once deemed a desirable skill is very quickly becoming an expectation amongst physicians across a wide range of specialties. Now let us move on to the first topic of this lecture, that is lung ultrasound. Again, I will discuss this topic by highlighting three case examples in which lung ultrasound was used clinically to diagnose and direct therapy. The first case is a 56-year-old female patient who sustained a left radial fracture after a fall on an outstretched hand. Other than her radial fracture, she had no other injuries and had no significant medical history of note. The anesthetic plan for this case involved performing a supraclavicular block and supplementing this with monitor anesthesia care so long as we were happy with the effect of the block. This block was performed by the block team under ultrasound guidance. And here we can see in this image, we have a picture representation of the characteristic image seen when performing this block under ultrasound guidance. Note in this image the location of the brachial plexus and its proximity to the lung pleura in this image. During the procedure, the patient did very well. According to the block team, it was a very uneventful procedure. She was given 2 milligrams of midazolam, which had a good effect, and she was stable throughout the procedure. However, approximately 20 minutes after the procedure, it was noted that the patient was objectively and subjectively more dyspneic, and her O2 saturations were lowered to the low 90s, having previously been normal at 99%. On top of our differential diagnosis is, does this patient have a pneumothorax after her block? Remember that the pleura is very close to where we inject for a supraclavicular block, and a pneumothorax is a well-known complication with this block. Our patient is not clinically unstable at this stage, however, so further investigation is prudent. And usually this takes the form of a portable chest X-ray. However, is there a role for lung ultrasound in the evaluation for pneumothorax? Well, the evidence here is very clear-cut. Not only is lung ultrasound feasible, but it is also sensitive and specific for the detection of a pneumothorax. So this modality can certainly be of value in a patient such as the one we've just presented. Now that we have decided that ultrasound could be of benefit in our patient, how do we go about examining the pleura to rule in or rule out a pneumothorax? In terms of equipment, we generally use the linear probe for this exam. This probe is best since the pleura is a very superficial structure, and this high-frequency probe is very good for superficial structures. When examining the lung using ultrasound, we typically divide the chest into 8 segments, 4 anterior and 4 posterior. In a supine patient, air tends to rise, so the anterior segments are often where a pneumothorax will be detected. Segments 1 and 5 in this diagram. When we put our ultrasound probe in the chest, we should see 2 dropout artifacts or acoustic shadows at either end of the image. These are the rib shadows, the superior rib to the left and inferior rib to the right. Between the rib shadows, we have the lung pleura, and it is the movement of the lung pleura that we are assessing when examining for a pneumothorax. This movement of the lung pleura is often described as lung sliding or ants marching, and is due to the opposition of the parietal and visceral pleura with respiration. Again, we have another example of lung sliding, where we have the classic shimmering line as the patient takes a breath. This is a normal finding. We can further visualize this pleural sliding using M-mode. And for this, we place the M-mode cursor through the pleura. And what we see here is the classic seashore sign. Subcutaneous tissue above the pleural line, represented by the yellow arrow, generates horizontal straight lines, while there is a sandy appearance below the pleural line created by the movement of the lung sliding. Next, looking at a patient with absent lung sliding, and what we can see from this example is we have lost the characteristic shimmering of the pleura that we saw in the previous example. And this is a patient who may have a pneumothorax. When we place an M-mode cursor through the pleura in which we were examining, there is no lung sliding, and we get our characteristic barcode sign, as seen in this image above. In this image, we see uniform parallel horizontal lines above and below the pleural lines, and this is due to lack of motion in the chest wall or lung. When we see an image like this, we should be highly suspicious of a pneumothorax. Going back to our patient who had her supraclavicular block and became dyspneic and hypoxic after the block, when we placed the linear ultrasound probe on the upper anterior portion of this patient's left chest, we could not appreciate any lung sliding. And when we put the M-mode cursor through the pleura at this point, we obtained the characteristic barcode sign. Both of these together, along with the history of a recent supraclavicular block, made the diagnosis of a pneumothorax very likely. This patient was clinically stable, and so we were not concerned about a tension pneumothorax. So a chest X-ray was performed to ascertain whether she required an intervention. The chest X-ray confirmed a moderately sized left pneumothorax that was clinically significant, and so subsequently, this patient had a chest drain inserted in the PACU and had a good re-expansion of her lung, and her oxygenation and dyspnea improved. This case highlights the utility of lung ultrasound in the diagnosis of pneumothorax. Moving on to our second case, and now we have a 76-year-old gentleman who is undergoing an elective open aortic abdominal aneurysm repair. His background history includes hypertension, hyperlipidemia, diabetes, and heart failure with reduced ejection fraction. The anesthetic plan for this patient was general anesthesia, invasive monitoring with an arterial line and central venous catheter, along with a thoracic epidural. This was a long procedure, and he was relatively stable throughout the surgery. However, there was significant bleeding intraoperatively, and he was resuscitated in the form of crystalloid and blood products. At the end of the procedure, he was hemodynamically stable with a normal arterial blood gas, and so was extubated on the table and initially did very well. This patient spent the evening and night in the PACU, and following his surgery, it was noted that his oxygen requirements were increasing in the PACU. He was initially on nasal prongs, then moved to oxygen delivery via face mask, and was now upgraded to high-flow nasal oxygen. So what do we think is the cause of his hypoxia? And is there a role for lung ultrasound in this patient? Well, given this patient's history of having a central line cited for the procedure, it is most certainly prudent to evaluate for a pneumothorax. And when we examine the chest, we see lung sliding and a characteristic seesaw sign in all segments. So we can effectively rule out a pneumothorax in this patient. How about assessing for pulmonary edema? Can ultrasound be useful in this situation to assess for pulmonary edema? Well, again, the evidence here is very clear in that lung ultrasound is a very simple, effective, and sensitive method for the semi-quantitative estimation of extravascular lung water. So now that we have decided we want to examine this patient for pulmonary edema, how do we go about examining the lung for pulmonary edema in this patient? So for this examination, we are examining structures deep to the pleura. And so we want to choose a probe with a good penetration. So in general, we will use the phased array probe. However, the curvilinear probe could also be used in this situation. Similar to before, we will sequentially examine all 8 quadrants of the chest using ultrasound before we make any determination of whether this patient has pulmonary edema or not. That is to say, we will examine the 4 anterior segments and also the 4 posterior segments. In general, evaluation of an air-rich organ such as the lung is a limitation of ultrasound because air scatters the ultrasound beam and does not allow proper visualization of the underlying structures. Therefore, we cannot exactly see the lung tissue like we see, say, the kidney on ultrasound, unless there is consolidation. However, this limitation paradoxically turns into a diagnostic advantage when doing lung ultrasound because of the characteristic artifacts that are created, such as A and B lines. It is in fact these artifacts that we examine when performing lung ultrasound to assess for pulmonary edema. When we talk about A lines, these are hyperechoic horizontal lines arising at regular intervals from the pleural line seen in normal aerated lung, such as the image portrayed. They are reverberation artifacts that can simply be considered as reflections of the pleural line. Here we have another example of A lines. Again, these are hyperechoic horizontal lines arising at regular intervals from the pleural line. B lines are defined as discrete laser-like vertical hyperechoic ring-down artifacts that arise from the pleural line and extend to the bottom of the screen without fading, and they move synchronously with lung sliding. B lines are reverberation artifacts that originate from water-thickened pulmonary interlobular septa. A positive B line region constitutes presence of 3 or more B lines in one rib interspace. 2 or more positive regions bilaterally is defined as interstitial syndrome and indicates diffuse pulmonary edema. Here we see another example of a patient with B lines. And again, these are vertical hyperechoic ring-down artifacts that arise from the pleural line and extend to the bottom of the screen. The number of B lines present directly correlates with the degree of pulmonary edema. While it may be a normal finding to have 1 or 2 B lines in a segment, when we see 3 or more B lines in one rib interspace, it is an abnormal finding and is considered a positive region. As stated before, when we have 2 or more positive regions bilaterally, then the patient has pulmonary edema. So going back to our patient who underwent his open AAA repair and had extensive volume resuscitation, when we did a lung ultrasound, we visualized multiple B lines in multiple segments bilaterally, indicating that this patient had pulmonary edema, and this was the cause of his respiratory distress. We also did a point of care cardiac ultrasound, and this patient had a dilated left ventricle with poor left ventricular function. So he obviously couldn't handle the rapid fluid shifts that occurred during the procedure. Looking at his pre and post chest x-ray, we can see a dramatic change with significant bilateral interstitial edema present in his post-operative chest x-ray. Using our knowledge gained from lung ultrasound, we were now very quickly able to accurately diagnose post-operative pulmonary edema in this patient and subsequently commence therapy in the form of diuretics, CPAP, and IV nitroglycerin. These medications had a good effect, and the early intervention saved this patient from being reintubated in the PACU later that night. The point of care nature of lung ultrasound in the diagnosis of pulmonary edema is really highlighted in this case. Our final case with regard to lung ultrasound involves a 64-year-old male patient who was undergoing a minimally invasive rotator cuff surgery. His background history included an extensive smoking history, and he had severe COPD to the extent that he was requiring nocturnal oxygen therapy. This patient was as optimized as he could be for the surgery. However, he was still symptomatic with his COPD. And subsequently, our anesthetic for this patient involved an interscalene nerve block, and we planned to use minimal sedation during the procedure. Our aim was to avoid endotracheal intubation and minimize narcotics at all costs, and we felt this was our best plan with this exact patient. The patient was very agreeable to the plan, and he subsequently underwent an ultrasound-guided interscalene nerve block, which was performed by the regional team. The block went very smoothly, and the patient was very stable throughout the procedure. He was given 1 milligram of midazolam and had supplemental oxygen with his O2 saturations in the normal range throughout the procedure. 30 minutes after the block was completed, it was noted that the patient was significantly more tachypnic, hypoxic, and overall looked very unwell with regards to his respiratory status. So what are we thinking in this situation? Could this be a pneumothorax? Could this be acute pulmonary edema? Well, when we examined the patient for lung sliding on the side on which he had the nerve block, we could clearly see lung sliding and the seashore sign again, indicating that there was no pneumothorax in this region. We also couldn't find any evidence of pulmonary edema, as no B lines could be identified in any quadrant. So effectively, pulmonary edema was not the problem here. Thinking about the intervention this patient underwent, that is the interscalene block, we must remember that this block often takes out the phrenic nerve, resulting in hemidiaphragm paresis. And in a tenuous patient such as our patient here, this could result in acute decompensation. So that leads to my next question, in that does ultrasound have a role to play in assessing the diaphragm for phrenic nerve paresis? Well, again, lung ultrasound has been shown to be very effective in evaluating diaphragmatic motion. And this is a very quick and easy test to perform at the patient's bedside. So how do we go about examining the diaphragm in order to assess the movement of the diaphragm? Well, the ideal probe to use for this examination is the curvilinear probe, since we need good tissue penetration. Although again, the phased array probe can also be used in this situation. When examining the right side, the probe is positioned in the 9th to 11th intercostal rib space along the right mid-axillary line, with the marker facing towards the patient's head. The liver acts as an acoustic window on this side. The ultrasound beam is generally directed slightly posteriorly so as to visualize the diaphragm. When examining the left side, it is the same procedure, except now the spleen is used as the acoustic window. When performed, this is the image that is obtained with the liver in the center of the picture, and we can clearly see the movement of the hemidiaphragm with respiratory motion. This movement can be objectively quantified using M-mode so as to calculate the degree of movement. Contrast this to a patient with hemidiaphragm paresis, where we see minimal movement of the diaphragm during respiration. When M-mode is used, we can see that there is very little change in the movement of the hemidiaphragm during the respiratory cycle. So circling back to our patient who had an interscalene block and who is now in respiratory distress, we decided to perform a lung ultrasound looking at the diaphragm on the side where he had his block, and we could not appreciate much motion of the diaphragm at all. We compared this to the left side, where we could see good excursion of the diaphragm during respiration. So with that, we were very quickly able to diagnose the issue with this patient. This patient had developed acute respiratory distress due to hemidiaphragm paresis, secondary to local anesthetic acting on the phrenic nerve. We were able to support this patient with non-invasive ventilation, and we also delayed the surgery for another time. This case is a very good example of the power of ultrasound in evaluating pathologies involving the diaphragm. So moving on to how we utilize gastric ultrasound in the perioperative setting to aid in decision-making. And to do this, I'm going to go through two cases and highlight how we use gastric ultrasound so as to ascertain aspiration risk and also to direct clinical care. The first case is a 27-year-old nulliparous woman who has had an uneventful pregnancy, except that the fetus was found to be in the breech position in the third trimester. She had a failed ECV and it was scheduled for an elective lower segment cesarean section at a later date. However, she now presents in early labor. The fetal heart rate tracing is normal and mom is not in too much discomfort. According to the obstetricians, there was no urgency in delivering. However, they would like to get it done sooner rather than later, as it is now approaching midnight. When we go to talk to the patient, she says that she is MPO for solids for the last 4 hours and liquids for the last 2 hours. So looking at the guidelines as set out by the ASA, and the recommended time for fasting for adults undergoing a surgical procedure is 6 hours for solids, or 8 hours if fatty or fried food is ingested, and also MPO 2 hours for clear liquids. While these recommended fasting times are helpful in stratifying aspiration risk, they are not applicable to everybody. Some patients will be fully fasted before the 6 hours, and some patients may take longer than the 6 hours. So my question is there a role for gastric ultrasound in individually stratifying aspiration risk for patients undergoing surgical procedures? Well, the evidence would suggest that not alone is gastric ultrasound feasible in assessing gastric content and volume, but it is also quite accurate and easily done and can very well stratify patients as it regards to aspiration risk. So how do we go about performing gastric ultrasound on our patients? When examining adults, a curved array, low frequency transducer is used with standard abdominal settings selected. Using this transducer allows sufficient penetration of the abdominal compartment so as to produce sonographic images of the key landmarks required. When examining the stomach, it is the antrum we typically examine, as the fundus is often difficult to visualize on ultrasound, and the body of the stomach often contains air and so not very amenable to ultrasound. In terms of patient positioning, both supine and right lateral decubitus positions may be used to locate the gastric antrum. In the supine position, large quantities of gastric content will be readily visualized in the gastric antrum, but smaller quantities may remain within the gastric fundus. In contrast, the right lateral decubitus position encourages gravitational drainage of gastric content to the dependent antrum and increases the sensitivity of ultrasound to detect smaller volumes. If the patient is unable to turn to his or her side, then a slight head-up position can also be used. The ultrasound transducer is placed perpendicular to the skin, sweeping from the left costal margin, seeking the following key sonographic landmarks from deep to superficial. They include the vertebral bodies, the long axis of the abdominal aorta, the head or neck of the pancreas, the inferior margin of the left lobe of the liver, and the gastric antrum in short axis. The liver provides a nice acoustic window to the gastric antrum, which can be distinguished from other hollow viscera, such as duodenum or bowel, by its thick hypoechoic muscularis layer, along with the hyperechoic serosa and mucosal layers. The first part of the gastric ultrasound examination is to perform a qualitative assessment to determine if there is any solid or liquid material in the stomach. If we see any solid material, then the patient is not fasted and high risk of aspiration. Whereas if we see fluid in the stomach, we then need to quantify the amount of fluid in order to assess aspiration risk. When the stomach is empty, it appears small, flat, and collapsed in both the supine and lateral positions. The walls of the stomach can appear relatively thick, and when round or oval in shape, it has often been described as having a bullseye appearance. it may be possible to observe the multiple hyper and hypoechoic layers of the gastric antrum when empty. In particular, the muscularis mucosa may be prominent when the muscle is in a relaxed state, as seen in this image. Gastric secretions and clear fluids, such as water or black tea, appear hypoechoic in appearance. When containing fluid, the antrum begins to distend and become thin-walled, unlike the thicker-walled appearance in an empty state. The hypoechoic muscularis layer also becomes thinner as the antrum distends. The physical process of swallowing is inevitably associated with swallowing of air as well. Thus, recent consumption of clear fluids or carbonated drinks can produce air bubbles within the fluid that may appear as hyperechoic dots, as seen in the anterior portion of this image of the stomach. Thick fluids appear hyperechoic with a heterogeneous consistency within a distended antrum. The full circumference of the antrum will be visible, and peristalsis might be apparent. And we also may appreciate movement of particulate matter within the antrum. Chewing and swallowing of solid matter are invariably associated with the ingestion of air, as stated before. In the early stages after solid consumption, this air prevents sonographic visualization of deeper structures and created what is called the frosted glass appearance. No structures deep to the anterior wall of the antrum are seen, as demonstrated in this image where we see the frosted glass appearance. So going back to our patient, we decided to perform a gastric ultrasound in order to make an objective decision regarding her fasting state. When we placed the gastric ultrasound in the patient's abdomen, we could clearly identify that her stomach was completely empty, as indicated by the so-called bullseye appearance on ultrasound. As we can see here, the antrum appears small, flat, collapsed, and the muscularis mucosa is very prominent. So with that, we were able to decipher that the patient is fully fasted and it is safe to proceed with the procedure, despite her not meeting the 6-hour recommended guideline for fasting. Moving on to our second and final case today, this is a 93-year-old male who sustained a hip fracture after a fall and was scheduled for operative repair. The floor nurse looking after him stated that while he was adequately fasted for solids, she thought that he may have drank some liquids recently. So at this stage, we have unclear fasting times for liquids, and the decision is to either cancel or delay the case, or can we make a more objective decision with gastric ultrasound? Putting the ultrasound on this patient's abdomen, we have the following image, and this clearly shows liquid in the gastric antrum. So we now know that this patient has liquid in his abdomen, but does this put him at increased risk of aspiration risk? Well, in order to answer this question, we need to perform a more quantitative exam in order to determine the exact volume, which will determine his aspiration risk. To do this, we measure the cross-sectional area of the gastric antrum. Two methods are used to measure antral cross-sectional area. The image on the left illustrates a method based on two perpendicular diameters, while the image on the right illustrates a free tracing method following the outer border of the antrum at the level of the gastric serosa, with the latter method being the easiest and most commonly performed. In our patient, we calculated the cross-sectional area to be 16 centimeters squared. So what does this number mean? Well, based on the cross-sectional area, we can estimate gastric volume. And in general, a patient is determined to be adequately fasted when less than 100 cc of liquid is present in the gastric antrum. As we can see here, our patient had approximately 150 cc of fluid, and so this patient is not adequately fasted. So with that, we were able to make an objective clinical decision and delay surgery for a further 1 hour and proceed after we have repeated the gastric ultrasound and confirmed that there is sufficient gastric emptying. So that wraps up our lecture today on lung and gastric ultrasound. I hope that through our case-based discussion today, I was able to convey to you all the potential utility of using both lung and gastric ultrasound in the perioperative setting and provided you with a framework to begin learning this important skill. Thank you very much, and I look forward to the panel discussion.